Bismillahirrahmanirrahim. The topic of today's discussion is blood cell morphology. In blood cell morphology, first of all, we would read why we study the morphology. Morphology of the blood cells is mandatory for diagnostic information. The blood film should be examined carefully and systematically. The film should be mounted with a cover glass, and there should be a neutral mounting medium that provides good refraction and also preserves the blood film. First, it should be examined under the low power lens, that is 10x objective, and this will give the idea of the quality of the film, like distribution and staining of the cells and the platelet aggregates. It also gives idea about the rouleau formation and the presence of agglutination, dimorphic population, and the presence of some hemoparasites, for example, microflare. Then we switch to a dry high power 40x objective, and then the oil immersion 100x objective should be reserved for the study of the finer details of the cells. There are three types of cells in the blood. There are RBCs, WBCs, and the platelets. Each should be studied systematically. First of all, there will be the RBC morphology. Now the RBC morphology. Normal red blood cells are circular disc of 6 to 8.5 micrometer in diameter. Roughly, their size is almost equals to the nucleus of the small lymphocyte. The bright reddish color on the periphery and central is pale. That gives RBCs a biconcave shape. The central pale area is normally not more than 1/3 of the total RBCs area. In a normal film, the RBCs lie separately in the central area of the film. RBCs are examined for their distribution, for their size, for their shape, for their color, hemoglobin content, and inclusions. Abnormalities in these characteristics may be artifactual or due to any disease. For example, if there are change in the plasma proteins or there are antibodies to the RBC surface antigens, or there will be abnormal erythropoiesis or increased erythropoiesis, or there will be inadequate hemoglobin formation or damage to the red blood cells in circulation. Now, the abnormalities of distribution. First of all, there will be the rouleau formation or there will be agglutination. Rouleau formation is a stacking of RBCs on the top of each other, which is seen when the fibrogen concentration of the blood is increased. For example, in infections, pregnancy, and tissue necrosis, when there will be the fibrinogen concentration will be increased, such as in pregnancy or tissue necrosis or infection. Rouleau formation is a stacking of RBCs just like on the top of each other, just like the coins, and it is due to the increased fibrinogen concentration in the blood. For example, in infections, pregnancy, and tissue necrosis, it is characteristically seen in condition with abnormal globulin production. For example, in multiple myeloma, the degree of rouleau formation is directly proportional to the ESR. ESR will be increased if there will be the rouleau formation and the fibrinogen content of the blood is increased. Rouleau formation occur in conditions such as multiple myeloma, infections, tissue necrosis, or pregnancy. Agglutination. Agglutination is defined as a random aggregates of RBCs. There will be the clusters of varying number of cells, varying number of RBCs in the form of clusters. This results from a bridging of cells by the antibody molecules, particularly the IgM against antigens on the surface of RBCs that are circulating in the plasma. These may be produced endogenously. Either there will be the autoantibodies, as in cold autoimmune hemolytic anemia or cold hemagglutinin disease, or rarely introduced from outside, for example, an infusion of the large amount of mismatched plasma. In the case of incompatible blood transfusions, the agglutinates seen comprise of the donor's original red cells. Now, the abnormalities of the size. Anisocytosis, microcytosis, or macrocytosis. Anisocytosis, the size of the RBCs varies in the same blood film, is termed as anisocytosis. Beyond the normal limits, that's why it is called anisocytosis. It is expressed as 1 positive to 3 positive, and it is a non-specific feature of several hematological disorders. Now, the second is microcytosis. Microcytosis, when the average size of RBC in the blood film is less than normal, is termed as microcytosis, and the degree of microcytosis is directly proportional to the decrease in MCV. It is directly proportional to MCV. Seldom occurs alone, but is usually accompanied by hypochromia. Usually, microcytosis occur along with hypochromia. Seldom there will be no relation. Microcytosis is commonly seen in iron deficiency anemia and thalassemia. Iron deficiency anemia and thalassemia Sometimes the small cells with no central pallor are seen, and these usually have normal MCV and they are termed as spherocytes, right? Sometimes there will be the small cells with no central pallor, and they have usually normal MCV, and these are termed as spherocytes. Next, there will be the macrocytosis. The macrocytosis, when the average size of RBCs is more than the normal, like the RBC size is greater than 6 to 8.5 micrometer diameter, it is termed as macrocyte. The degree of macrocytosis is directly proportional to the increase in MCV. Just like the microcytosis, there will be a decrease in MCV. Same as that, in macrocytosis, there will be increase in MCV. The common causes of macrocytosis is the liver disease, megaloblastic anemia, aplastic anemia, refractory anemia, obstructive airway disease, excess of alcohol, treatment with hydroxyurea or hyperglycemia. In patient whose marrow is responding by increased hematopoiesis, there are a lot of polychromatic cells, and these appear as macrocytes. When the bone marrow is responding, there will be the increased hematopoiesis, and there will be a lot of polychromatic cells, and the polychromatic cells usually are larger than the normal RBC size, and they present as macrocytes. Now the abnormalities of color, the only two variation in color is hypochromia. It results from the decreased hemoglobinization of RBCs, commonly seen in iron deficiency anemia and thalassemia. The degree of hypochromia is directly proportional to MCHC. The degree of hypochromia is directly proportional to MCHC, and it occurs in iron deficiency anemia and thalassemia. The only two variation of color is hypochromia. Leptocytes may be appear hypochromic because of the flattening. Leptocytes may be hypochromic due to flattening, and spherocytes appear hyperchromic because of their loss of the central pallor area and increased thickness of the cell. The macrocytes may also appear hyperchromic because of the increased thickness. So, there is no hyperchromia, but in few conditions the cells appear as hyperchromic. Just like the spherocytes maybe appear as hyperchromic, or macrocytes appear as hyperchromic cells because they have increased thickness of the cell. Target cells have the central hemoglobinized area surrounded by the pale ring, and then there is a peripheral hemoglobinized area. Like there are two hemoglobinized areas, and center is the pale ring. These are usually result from the increased membrane surface due to the increase in the cholesterol and phospholipid content. Membrane surface is increased due to the increased cholesterol and phospholipid content. The target cells are characteristically seen in thalassemia, HBC disease, HBD disease, HBE disease, obstructive liver disease, post-splenectomy, iron deficiency anemia. If they are artifacts, then these are confined to only portion of the blood film. Okay? If there is artifact, they will be confined to only one portion of blood film, not to the whole of the blood film. But if target cells are present in whole of the blood film, then the differential diagnosis could be thalassemia, hemoglobin C disease, hemoglobin D disease, hemoglobin E disease, obstructive liver disease, post-splenectomy, or the patient may have iron deficiency anemia. Now the dimorphism. The dimorphism is termed as when there are two distinct populations of the RBCs are seen in the blood film. One population is normal and the other is abnormal, particularly the hyperchromic microcytic or macrocytic. Dimorphism seen in sideroblastic anemia, when a patient has been transfused or when a patient is receiving hematinics for treating a deficiency anemia. Now the abnormalities of the shape, the poikilocytosis. When the shape of the RBCs varies more than expected for normal individuals in the blood film, it is termed as poikilocytosis. The abnormally shaped RBCs is termed as poikilocyte. The poikilocyte is also a non-specific feature in several hematological disorders. There will be abnormal erythropoiesis, there will be megaloblastic anemia or myelodysplastic syndrome, iron deficiency anemia, thalassemia, or myelofibrosis.